Okay, so the first question is, if I'm finally starting to improve after 18 months, I'm by no means back where I was, but better. Would ivermectin work well, or do I hold on and wait for what winter brings in terms of different strains? I have mild bronchiectasis. Would a steroid pump help? I get wheezy, never had this pre-COVID. I'd like to exercise again, but feel my lungs don't want to.
This is there's many to that, and we've looked at ivermectin. I think, I mean, I would be looking at, how do you, the mild bronchiectasis, how is that measured for a start, which is bronchiectasis, the people that don't know, is essentially, isn't it, Andrew, like collapse, a partial collapse of some of the airwaves. And and I had that myself, I don't know whether I still have it, but when I last had an MRI scan about 4 months ago, I still had some bronchiectasis in my left lobe of my lung. So if we are not breathing properly, if we're not engaging the right, the inhale, the exhale, the full inspiration, we're going to be, partial collapse of our lungs is going to happen because essentially we're not using it, right? So the lungs get lazy. So there's many reasons why we might, this might happen in COVID, but a lot of the time we become, if this is your experience too, but you almost become a bit scared to take a breath because of pain and because of discomfort. And so you find yourself like breathing around the pain, which then means that those areas of partial collapse can worsen. So my recommendation there would be a few things. I would encourage you to do breath work. And if you look, we did an interview with the Breath Guy on Jez's channel recently to talk about the power of breath work and really opening up the lungs. I have found it really helpful. There's also a book called The Oxygen Advantage by Patrick McEwen, and I met him recently, and he did a lot of discussion around dysfunctional breathing patterns in long COVID, particularly with carbon dioxide tolerance. And you can measure that in basically how long you can hold your breath for. It's something called the BOLT score. So you take a deep breath in, deep breath out, and then you basically clamp your nose and then keep an eye on how long you can hold your breath for. And I think it's a good score is like 35 seconds, but often with long COVID, many people don't get over like 20 seconds. So that would be one thing you can look at. So breath work comes in many different forms. I'd also be looking at, I used an infrared sauna for a long time when I had long COVID because I found it very helpful for my lungs. One of that is perfusion, right? It's just increasing blood flow to the lungs and to the chest wall directly. So that really helped. Also red light therapy, which Andrew, as I've mentioned, has an amazing contraption called the Novathor in London, which that can really help lung function. Steroid pump, I mean, I'll push this over to you, Andrew, because you have a lot of experience with respiratory physiology in this sense, but would you go for a steroid pump, or I can then tell you my experience with using steroids for my lung condition post-COVID.
So I think the other piece about bronchiectasis, it's a suppurative lung condition. So it's a mucus forming condition. So it's the mucus which is clogging the airways. You've got an inflammatory component to it too. If you've got a lot of extra mucus sitting around, then that can very easily become infected. And so people with these kind of conditions can get frequent infections. They're more prone to things like flu taking hold when those settle in. So, I mean, just as a very basic point, anything you can do to reduce mucus production, which could include a steroid inhaler, because at least it's going to be having a local effect rather than the systemic one, but also trying to avoid mucus forming foods. And just remember things like, wheat and gluten, sugar, shellfish, orange juice, and dairy are all highly mucus forming foods. So just sort of culling those down could just make all the difference from just reducing the mucus around, reduce risk of infection, reduce risk of the airways being clogged up as a practical point. Steroid inhaler, maybe if you've been on a steroid inhaler before, it can be very helpful just to reduce that inflammatory piece, and you're not getting all the horrible systemic side effects to such a great deal. A flu vaccine might be worth considering, just because you're going to be more prone to viral infections taking hold and becoming secondary bacterial infections. Breathing work, as you said, really helpful. I'm a really big fan of the red light thing. That's my latest thing at the moment. It seems to be having some really good benefits for people with long COVID. Because one of the things it does is it targets the mitochondria, and these are the things in your cells which produce energy and which get hit when you have long COVID. Had some really good results so far. Obviously, you can't go around making claims about long COVID because it's a very sensitive subject, but certainly anecdotally, we're having some great success with using red and near infrared light as a whole body treatment.
Yeah, absolutely. So my own experience, and Jez, I don't think you had much in the way in respiratory issues, did you? No. So I did did a lot of what Andrew's talked about, but I was prescribed a steroid inhaler, and it really didn't suit me because I think I got recurrent thrush on it, oral thrush, in the back of my mouth, even though I don't know, I think it was the immunosuppressant effects, plus I couldn't sleep when I took a steroid inhaler. So I don't think that was that helpful. What I did find unhelpful was doing nebulizing. So I bought a nebulizer on Amazon, Omron, and I nebulized basically saline. I upgraded a bit and used some glutathione, which can the whole point of a nebulizer is it delivers things directly to the lungs so it can open them up. So nebulizing saline, glutathione can really help the lungs. Orally, I took a lot of N-L-acetylcysteine. I think that helps the lungs. Garlic's very good for the lungs, bizarrely. Anything else you want to point out that's good for the lungs?
No, you quoted all the things I really like. I really like the nebulized glutathione, and garlic is a fantastic antimicrobial. It's a panacea for just about everything, including viral, bacteria, fungi. It's actually really helpful. So, yeah.
But I mean, so it's not.
Oh, thyme, actually. Thyme is my other one.
Yes.
Thyme is a herb. Very, very good.
That's interesting. I got some thyme here. Look, I chew on it.
So you could either have it in the food or actually as an essential oil burner. So you're actually inhaling the vapor. Is a really good one. Very good antimicrobial. It's got a selectiveness for the chest.
Yeah.
Are we allowed to say sea air as well? Is that on the list of things we can prescribe?
Oh gosh, yes.
So it's worth saying that I had flare-ups. You mentioned bacterial flare-ups because I had inflammation in the lungs and I was getting secondary infection in the lung. A number of reasons why, probably getting run down, having episodes of bronchiectasis. But since I've moved to Spain, where I'm working at the moment, I haven't had, touch wood, any problems with my lungs at all. And I have been swimming in the sea. Obviously, the air is a lot more humid and warm. But I do think that makes a big difference, for sure. So yeah, I hope that's, you feel like your lungs don't want to. There's a part of this is, this is a tricky one. And again, Jez, you've covered this with the kind of illness identification and how much should we exercise when we've got long COVID. I do think that a little bit of exercise to prevent complete deconditioning is important, but it's a very fine balance, isn't it, Jez, as we've found out. That's why I think the breath work, which is engaging your respiratory and respiratory muscles generally, is important. I think systemic exercise, in my experience, non-impact exercise has been far more beneficial for my body, like swimming, like yoga, walking, if you can tolerate it, but really focusing on your breathing at the same time. So I think a little bit of exercise is important, but don't come back feeling absolutely exhausted that you can't do anything for the rest of the day. So yeah. That would be my, and ivermectin. Well, ivermectin, good. Jez, you go on ivermectin, then I'll give you my experience.
So look, I mean, the ivermectin thing is a hot potato, isn't it? In all sorts of different dimensions. I think the evidence for how much it helps people with long COVID is a bit mixed. Some people say, oh, I felt loads better. Other people are like, well, I've done it loads and I haven't felt any better at all. I mean, it's just about the only thing we've got that we think might impact on sort of viral replication if there was viral persistence. So maybe the people for whom it's been very effective did have some level of viral persistence that somehow the ivermectin's got through to those tissues and helped eliminate it, whether it's in the gut or elsewhere. And the people for whom it's not so effective, maybe they didn't have any viral persistence. We just don't have an answer to that question yet at a fundamental level. Is the virus still in our bodies replicating or not, to be able to answer it? And even if we did, we don't really know how effective ivermectin is at actually getting to the tissues where it might be. So
it's that, isn't it? For sure.
So it's a big question mark, really, ivermectin. It works for some people, not for others. Yeah, who knows?
Again, it might be a tool in the toolbox. I think, people are asking to have it prescribed, and as a doctor, you first do no harm is your premise, right? So I think it's well tolerated. I don't think Andrew, you can elaborate on this. My own experience of taking, 3 mg a kilogram every other day, 5 times through. I don't know. I think because we know it has anti-inflammatory properties, right? It doesn't just have anti-parasite, anti-COVID action, because the very reason it's used in dermatology is its effect on the inflammasome in the body. So I think it did help to some degree. But like you said, Jez, I think the more I think about this virus, the more I think that it embeds itself in our cells. And I think we're starting to see evidence to suggest that, right? And that we are getting reactivations, a bit like, I know it's a very different virus from herpes, for example, but, we're seeing all sorts of research coming out now that the viruses, can live in the body a lot longer than we thought, and trigger off, episodes of relapse occasionally. And, if you think about this from a sort of psychosomatic perspective, that's how it felt when you're really ill with this. It becomes like a war of, almost like consumption by this virus in different tissues and different cells of your body. And, it's almost like we have to reclaim ourselves from that. But that is a multifactorial process. So my thing is with ivermectin is that we really don't know yet. I know there's an Oxford trial going on about dosing. But, I don't think there's any harm in trying if you are still symptomatic, with inflammation, with joint problems, with maybe some gut problems, trying, the 3 mg per kilogram dose every other day, 5 times through.
I think you mean 0.3, maybe.
Sorry, I do. Yes. I was thinking about something. Yeah. So that for someone like me is something like 12 milligrams, someone like you, about 16 milligrams. Yeah. Good, thanks for that, mathematician. Andrew, have you had an experience with ivermectin efficacy-wise?
I haven't got any experience using it for long COVID. I've had a couple of patients that wanted to take it as a prophylactic because they had very complicated medical histories and they couldn't have the vaccine. So they wanted to use the ivermectin in the eye mask trial setting as a prophylactic. I've not had any side effects from them, but that's only a sort of N of 2. So I don't have any experience in long COVID. It's just they were trying it as a preventative strategy. But I haven't heard any bad things either. But I don't have that many people in the loop for that, I'm afraid.
Yeah, exactly. And it's probably worth saying that I have had people that have taken it prophylactically as well. And I feel like I've taken it when I feel like I've been exposed, and, there might be a placebo effect in that, who knows? But so, yeah. So, I mean, if we can't uber recommend it just because of the lack of data, but as data comes, we'll update what we do know about it. But it's getting hold of it as well. We use a compounding pharmacy to prescribe it. Otherwise, if you buy it as Stromectil, which is as it's used for worming, it's very expensive. It's like 150 quid for 3 tablets. So yes. All right, next.
Okay, next question. Hi there. Happy to report that I continue to experience improvement and recovery at the 18-month mark. However, I still seem to have some mild lingering heart symptoms, mostly subtle pain or discomfort, as though my heart feels irritated. And it seems to correlate with cardio exertion, with symptoms arising hours after the raised heart rate. My symptoms are much more mild than in the early stages, less in duration, intensity, and frequency. So do you think something like this could resolve further with more time? Are there any latest understandings about the long-term cardiovascular symptoms or treatment? My extensive cardio tests back in November 2020 were all normal.
Yeah, this is an interesting one because I also had this, although thankfully it's now gone away. I'm a bit further down. How many months are we now? If we were in March, it's kind of like 19, 20 months.
Yeah.
What my experience in this, if you've had scans and they're all normal, a lot of this is probably due to dysautonomia. I don't know if you agree. So that is essentially the innervation of the heart. And that doesn't mean that you can't get some heart inflammation, because you might on exertion get some very mild heart inflammation. We just don't know. So my feeling on this would be, if you have had reassuring scans, then I would be working on the premise that this is dysautonomia and looking at ways to improve your parasympathetic nervous system function, which again, as we've covered, relates to looking at breath work. We can link to a really interesting conversation with Patrick McEwen. He's done something on long COVID and breath work. I would be looking at other modalities that can support your nervous system. Cranial osteopathy, Jez and I have found that very helpful as well. We use a guy called Sam who works in Wimpole Street. We can link to him. He's been very helpful because, again, it's restoring the nervous system. It's working on the trigger happy immune nervous system relationship, which then means that, you know, it takes a long time to kind of calm down, which is why your heart probably feels irritated. I remember lying in the bed at night, just feeling like you've got this like sack of inflammation, of like fire, of heaviness in your chest, and I couldn't tease it apart whether it was heart or lung. And you know, I don't think we really know, but it feels very real. And it wasn't until, like, you know, Jez and I did the Bruce Patterson cytokine panels, which look at inflammatory mediators, and you know, a lot of them are way off what they should be, or a normative value for the population. So we finally, you know, you have evidence that there is inflammation floating around the body that normal tests aren't able to pick up. So that's almost like validation for your symptoms. But from my own experience, like I said, it's doing the work on your nervous system, which immune system connection. Jez, do you want to add anything there?
I think you've covered it. I don't have anything else to add.
Yeah, I mean, you noticed it yourself, right? When you were walking, with the whole classic dysautonomia aspect is going from, you know, a lower heart rate and then spiking up very quickly, which, you know, as previously fit people didn't used to happen.
Yeah. If I'm just faffing about outside, like my heart rate will go to 120, 125. I used to be able to run 5K like at a decent pace at a heart rate of 120, but now just faffing about in the garden and gently pottering is enough to do the same thing to my heart rate. So something's going on there. I don't think it's the heart itself.
No. It's like shock, isn't it? I see it as a shock. I see the COVID as an infection has caused shock in people, you know, a systemic shock, and that takes time to rewire, in my experience. And someone has asked quickly if we followed the Bruce Patterson protocol. So neither of us actually took up the protocol because it was basically too intense. And, you know, our own medical doctors or experts that we had looked at just weren't happy to prescribe, you know, an HIV drug, a statin, and an Ivermectin. And there was fluvoxamine as well, which is quite a strong anti-anxiety serotonergic drug. But we'll come back to that. Yeah, so I hope that's helpful. Yeah. I would just do a little bit, small things, you know, just build up to it, but don't completely do nothing because that will just cause deconditioning. And try and not label the process when everything seems like it's going wrong. You know, panic. The more you panic about the things feeling out of whack, the more that's reinforcing it within the body.
I'm saying a similar sort of thing, and I agree with everything you said. I mean, it's a combination of alternate dysautonomia that you mentioned. I think the histamine thing has got a part to play. I think inflammation's got a part to play. And then anxiety just helps driving up your heart rate and just increases the anxiety. And you get these vicious cycles of worrying about the symptoms. They're making your heart rate go up, and it just kind of perpetuates each other. I think, do you not use, you had an ankle device. Have you found that any benefit from an...
It's funny, I still use it.
The Apollo
it's so yeah, I've got it on now. It's so ugly, but I do use it, and it does various different modes. It's got one that, you know, relax and unwind. It's got a meditation mode. It's got a clear and focus mode, which is what I'm using now to try and make my brain stay on track. So I really like it. Apollo Neuro, it's called. And I remember being in A&E when in the height of COVID and anxiety and putting it on the like unwind, relax mode, and I think it made a difference. So it works just by sending a vibration into your nervous system, which is meant to sort of trigger a sense of safety, a bit like touch, right? Proprioception, touch, vibration, calming everything down. So I like it.
Good. I mean, I've got one as well, and I haven't got long COVID, but I find it really, really helpful. So if there's people out there that are thinking about trying to do something like this dysautonomia, it can be really helpful. I'm also looking into a vagal nerve stimulator, which you attach to your ear, to see if that can help, just to kind of rebalance the both sides of the autonomic nervous system. So there are some things out there we can try. They're pretty safe. Hopefully that's given some of you some suggestions.
Have you used that vagus nerve? Because there's some that are quite cheap. I had one called the Nirvana, Nirvana, but that was like 350 quid back in the day. I think you can get them quite cheaply now.
I've got one en route, so I'm just waiting for it to arrive, and I can sort of test it out and feedback. But I'm quite keen to see how it works. So. Good.
I've been using one and found it very effective.
One of the ear ones? Or?
Yeah, exactly. Yeah. I do it at the same time as my breath work, and I find that it just helps bring everything right down. I mean, the breath work does like half the job. The vagal nerve stimulators the other half. Yeah, really pretty quickly.
Excellent. Okay, let's go on to the next question. Some research is indicating that long COVID is an autoimmune condition. What are your thoughts? Did COVID trigger underlying autoimmunity, or did it cause it?
I think that's a question we don't know the answer to yet. I think what we are seeing, and my experience from talking to Dr. Paul Glynn on this and others, is that, you know, those people who are predisposed to autoimmunity, like, you know, women of my age and of my temperament, as it were, who are, you know, sort of perimenopause, high achieving, perfectionist types, are more prone to getting autoimmunity anyway. I had some hallmarks of autoimmunity in terms of Raynaud's and all of those kinds of things prior to getting COVID, and some nervous system, immune system dysfunction, living in a moldy house, etc. So I think the answer is there that, you know, I think there is an autoimmune component to COVID, but we can't yet measure it as such. You know, from my own blood tests I've looked at, and there's sort of mild dysfunction, cytoplasmic staining, but we don't have the autoimmune marker as we do for, say, rheumatoid or SLE, for example, to really know what the autoimmunity in COVID is at this time. You can measure something called total ANA, which in some people they found has been raised in long COVID. So, I mean, to extend that analogy any further, you know, some people are noticing a big benefit from something called LDN, low dose naltrexone, which is used in the functional medicine world to modify autoimmunity, to sort of regulate the immune system. We don't really know how it works, but it seems to affect some of the signaling pathways, and it's relatively side effect free. So that is something that some people are finding benefit from. Yeah.
So on the research front, Danny Altman has got an NIHR bid funded, and he's looking into autoimmunity. The preliminary results from that are suggesting that it does play a role in long COVID. Equally, there's a team in Berlin who had developed this new drug called BC007, which has been in the press a little bit. They've just had a big funding thing approved from the German government. That is, I'm not quite sure what it is, but basically it's something that gets in the way of what the autoantibodies do to to the cells that they then start blowing up. And it seems to basically antagonize that process, and seems to be very, very effective. And that's quite exciting as well. And that, again, suggests that autoimmunity is evolved. The other part that suggests that the immune system at some level is involved in all of this too is just how effective steroids can be for so many people on a short-term basis when they use them. So if I'm on a relatively low dose of prednisolone, 5 mg a day, something like that, I feel almost normal, you know, but it's not sustainable. And that's the problem with steroids. And the point at which I come off, I crash badly. And you've previously said, you know, there's no biological free lunch, Tam. And I think you're sort of paying the price of your metabolic dysfunction by using ATP you don't have. And that comes back to bite you. But fundamentally, the reason why those steroids make you feel better is because they're dampening down that immune response, and potentially the autoimmune response that's going on.
And the inflammation. It's why, you know, one of the reasons that professional cyclists or professional athletes, you know, dope with steroids, right? They reduce perception of effort, they reduce inflammation, which is a side effect of, you know, extreme events in the body. So there is that. So I try and support anything that supports the adrenal function or helps balance adrenal function can be helpful. Some people do really well on DHEA, which is an adrenal pro-hormone. So, you know, there's some evidence that can help with inflammation and brain function. I know, Jess, you've tried that as one of the many that you've had. I don't tolerate it because it makes my brain stay awake, but I can use the 7-keto DHEA formula, which I stay on at a dose of 25 milligrams. I find that helpful for adrenal function. And also other things that support the adrenals. Andrew, maybe you want to touch on that from your practice, what you would use in giving people adrenal rebalancing.
Sure. So I have a background in medical herbalism, so I'm always very keen to use botanicals that support adrenal function. And some of my favorites are things like rhodiola, eleuthero, which is Siberian ginseng, and the Olympic athletes in Russia and Siberia used to use this in preparation for races. It's a very, very rebalancing, recharging hormone for the adrenals. Licorice for people that are really depleted and not making enough of the hormones that their adrenal glands produce can be really helpful as well. DHEA, I agree with you, very good anti-inflammatory. It's got some useful steroid-like effects. those are my kind of top hits really for herbs. I think they, in combination, I think they work really well in combination as like a formula.
And you created one for us, didn't you, on Wellgevity?
I did.
Remind me of the name.
We've got, there's one in the pipeline. It's an adrenal formula. It's basically got a lot of the things that I've talked about in. So I think it's on the cards. It'll be coming out soon. But certainly that kind of combination is really helpful. Yeah,
exactly. I use Adrenatone by Designs for Health, which has got a lot of the things that you've mentioned. But again, that is shipped from America, so it's a bit of a pain. But yeah, good. All right.
Okay, let's go to the next one. Any recommendations on supplements for post-exertion malaise and muscle pain? Also, any thoughts on why, when I do too much, my first sign is my feet hurting so much that it's hard to stand up on the floor? I've been taking Design for Health nitric oxide support and it's helped tremendously too.
I just did a really interesting YouTube with Dr. Tommy Wood, who's a good friend of mine. And we covered many of those things, didn't you, Jez? What was it called again? The one that you did with Dr. Tommy Wood?
How to fix your metabolism.
In long COVID, yeah, which is relevant to this and other things. So, I mean, I'll just answer it quickly in terms of what can help. I really find that two things: creatine, which is known as a muscle building, sort of what they call the guys in the gym,
muscle weightlifters,
those people. Yeah, a little bit of creatine, and Dr. Tommy Wood reinforce this because it's very good at supporting mitochondrial function. So your brain can light up with a little bit of creatine. A lot of us avoid, or don't eat enough organ meats and red meat, which is where you find creatine naturally in the diet. So just supplementing with Prea Pure, just a powder of I think it's 5 grams a day, can really help. Also, in the same vein, something called D-ribose, which is I know Sarah Myhill, who's a big name in chronic fatigue and ME. Sorry, she highly recommends D-ribose. I notice a difference. It's a mitochondrial. It's kind of a form of sugar, isn't it? But it's not metabolized in the same way as glucose, so that can help. And what did she say? Oh yeah, hard to stand up on the floor. So a part of that can be dysautonomia, right? It's sort of like a pooling effect, isn't it? Andrew, I'll let you explain that, but that would be my thinking, because I get that as well. You just get swollen feet basically, and it's sort of a blood pooling effect.
Unless there's some kind of mechanical problem in the feet, which I don't want to completely ignore. So people that do a lot of sort of bounding exercise or impact exercise, if they've got like a fasciitis or anything in the sole of their foot, I'm just putting it out there. Not saying it's particularly in this case, but there could be a mechanical problem with the foot if it's specifically your feet you're having problems with. Interesting that the nitric oxide helps, because obviously that's just basically opening up the blood vessels and increasing blood supply. So that's interesting. But in terms of my kind of things for muscle aches and pains post-exertion, I've got a couple of things I like to use. Omega-3, just a panacea, anti-inflammatory, really helpful. Coenzyme Q, because there's often a mitochondrial element to people with long COVID, but also if they're getting muscle aches and pains for any reason, that can just give them a bit of basically giving the mitochondria a spark to help them generate energy. Curcumin is a kind of panacea, anti-inflammatory. And magnesium. People who are magnesium deficient often get muscle aches and pains and cramps, and we're often very deficient in magnesium. Magnesium doesn't often get into the red cells where it's really needed, so I think a good slug of magnesium, those are my top tips for muscle aches and pains post-exertion.
Yeah, so I use Electrolyte Synergy, which again is a Designs for Health product that has all of those things in. It's got vitamin C, which is helps histamine. It's got magnesium. It's got other electrolytes and D-ribose in it as well. It doesn't have creatine, but creatine is super cheap if you buy Prea Pure on Amazon for sure. But I think it's worth noting on this point, because I have this. I still have residual joint aches and pains, knees, wrists, etc. I have been using a GTN patch on the advice of, I don't know, someone in America, I think they were saying, because that is it's used in angina, basically. It's a nitric oxide donor, increased nitric oxide and vasodilation in the body, and that really helps. I notably have improved fibromyalgia when I use it. So, but as far as I know, they're prescribable products in the UK, aren't they? The GTN patch. But if literally 1/8 of a patch, you just cut it and stick it on the side of your leg. So that might be something you could explore with your GP, or through a consultation with one of us. I've noticed that's really helpful. But yeah, But given that you found nitric oxide support helpful, I know you use that quite a lot with people with heart conditions, don't you, Andrew, as well?
Yeah, very good for blood pressure, and it's actually very good evidence
Yeah.
for it as well. And I'm trying to get people off some of their nasty antihypertensives where they're causing side effects, and we're getting some good results. So, and it's derived from beetroot, so it's got a natural origin, but very effective.
We used to use that as an athlete. We used to use the beetroot shots. They're called Beat It. And the key with those is that you literally have to mix it with saliva to convert from a nitrite to nitrate to activate it in the body. But they are very effective at, or they were proven to improve, I think, VO2 max in athletes. And we know that blood flow is compromised in long COVID. So anything you can do to improve blood supply, blood flow, whilst noting that dysautonomia can often make it difficult to get the blood back into the heart, is helpful. Yeah.
Okay, next question. I would like to ask about vaccination. I had my first AstraZeneca vaccine 7 months ago into long COVID, as advised by my GP, when I was still unwell with long COVID symptoms. At that stage, it had taken me 7 months to be able to function slightly at home and walk outside for 20 to 30 minutes. Following the vaccine, I was immediately incapacitated again, where I couldn't get out of bed for weeks, couldn't function in the house, and couldn't walk to the bottom of my drive without feeling dizzy, faint, jelly legs, etc. It's taken me another 6 months to get back to where I was pre-vaccine, and I'm petrified of having a second vaccine now for obvious reasons. Is there any advice for me in this situation?
Can I just pipe up as the non-doctor?
Please.
So what's interesting is that in my most recent survey I've done, so I did 2 surveys looking at people's reactions to the vaccines, long haulers' reactions to the vaccines, relatively shortly on after their vaccines were available. So most people had the vaccine for 2 to 4 weeks at the point at which I was asking them. And those surveys seem to suggest that people responded positively more often than negatively to the vaccine. The survey I've done more recently now, which is basically looking at people months and months after they've had those first and second doses, interestingly, it's almost the other way around, where more people have responded negatively than positively to the vaccine in terms of their long COVID symptoms. And one other thing that I've seen a lot about here in Germany and people being treated at the apheresis clinic are people who, just like this person asking the question, have had their symptoms like massively, come on after a vaccine dose. And my advice for this person would be, generally speaking, you want to get the vaccine because you don't want to get COVID again, right? Getting COVID again is worse than getting the vaccine. But when you have a response to the vaccine that's that strong first time around, I would be reticent to go again and put another shot of spike protein into your body. But, we're coming into winter. Depends what your exposure level is going to be like. How much do you have to be out and about? Do you have a job, or do you need to be around people who are possibly going to have COVID? Because it's a really tough decision. But I think it's a decision you can only really make for yourself. But if you think that you can manage your risk levels, I probably wouldn't have the second jab.
That's where I am at, right? I had AstraZeneca, I don't know, about 8 months ago now, and felt rubbish for about 4 weeks. And then I haven't had it since. But my antibodies went from, detectable but not high to over 2,500. And at that point, when I had a discussion with Dr. Paul Glenn, he's like, you don't need another vaccine. Why would you? Why do you need to trigger happy your immune system again, saying you're full of them? No, the caveat to this, if I did a blood test, and I know I'm fortunate to be able to do blood tests and to check these levels. If my antibodies have gone to non-detectable, I would probably, and the T cell test, and we'll come to that, then both those are taken into account, I'd probably have another vaccine. But I'm kind of hoping that they're going to do a 2.0 vaccine, rather than keeping on with what we've got, that they're going to look at slightly more modified, less side effect. Well, who knows? Because it's the side effects that's causing the immune system response, which is causing what we think is offering the protection. So, my advice to people now is to check antibodies. The T cell test, you can do it at the doctor's laboratory. I think it's about 150 quid, which looks at if you've got non-reactive or reactive T cells or borderline. That is quite interesting, because you want reactive T cells, because that's what's doing the immune surveillance for COVID. So I hope that helps. And I'm telling people that do have the vaccine to take antihistamines, to take aspirin if there's no contraindications around the time of having it as well.
I agree with everything that's been said. I think it's a risk-benefit decision, and I've seen now enough cases of horrible reactions to vaccine to say that if you're constitutionally in a bad space, it's not a good time to have the second one, unless it's the risk of the COVID is going to be greater than putting you out of action for a while. I've seen massive inflammatory responses to vaccines. I've been in my other work where I do a lot of work with Alzheimer's patients. We do a very, very wide blood screen, and I've seen these really big spikes in inflammatory markers that can't be explained any other way than through the vaccine. Now, these are people that not necessarily had a reaction to the vaccine, but it just goes to show the inflammatory and immune response to it can be really significant. And for obviously the people who are more susceptible, it's really knocking them for six. So other things to support your immune system can come into play, high dose vitamin C, zinc, healthy diet, plenty of all the nutrients, plenty of water, being safe, sanitizing, wearing masks to kind of keep you out of danger if you can't really have the vaccine because of your personal situation. I've even seen quite a lot of nastier reactions to the booster. So people had the first two vaccines and they're fine having the booster and they're being knocked. So you just can't tell. But I think if you're in a bad space, it's probably not a good idea to have a vaccine unless you're massively high at risk.
Yeah, I agree.
Okay, got another question. So I got sick in March 2020. Any recommendations for muscle pain? I also have tingling on my right leg and right arm. I've taken the supplements you recommend. It has been a huge improvement. My sleep and energy are better after that. Thank you. So it's another one, I guess, about muscle aches and pains, but also these other sort of symptoms.
Neurosensory, yeah.
Yeah.
I mean, I've had all of this as well, and it kind of comes and goes, and it's difficult because you don't really have a test to measure it, this kind of neurosensory deficit. I'm not really sure if we have any answers there other than, again, going back to the nervous system work. I think, having things like hands-on therapies, I call them, so things that like touch, massage, or cranial osteopathy can really help these. Yeah, and the muscle pain generally, all the things we've touched upon, coenzyme Q10, I really like the GTN patch. That's the number one thing that's helped me. I use SPMs, which are the pro-resolve resolving mediators that have been shown to modify vascular inflammation. We used to get them from Spain, but now you can get them through Designs for Health. Pro-resolving mediators. They're basically a concentrated omega-3 fatty acid. Creatine, electrolyte synergy, curcumin, good doses of that can really help also. Yeah.
Okay. So one especially for you, Tam. How has your recovery been in terms of POTS dysautonomia? The internet makes some pretty grim reading about dysautonomia. Is there any hope for LC sufferers in terms of recovery?
Yes. Jez, where do you think you're? Well, I'll tell you where I'm at with my dysautonomia. Where do you think you're at?
Where I'm at with mine? Good question. I think it has improved. It's definitely improved from where it was sort of 6 to 9 months ago. It's probably one of my symptoms that's improved the most. But just when I think, oh, you know what, I can do more, my heart rate doesn't go mental anymore. I'll go outside and do a couple of jobs and I'll suddenly notice my heart rate's doing 130 and I'm like, where's that come from? So, but it doesn't get me in the POTS way. I know Assad struggles a lot with POTS. I don't have that, so I'm quite lucky in that respect. For me, it's just about spiking heart rates that remains high then until I lie down, do my breath work, put on the alpha stim, and then I can get my heart rate back down again. But it's it needs management. So I still need to be aware of it. Yeah,
I would say that I'm there as well. But I did have significant POTS when I first saw Paul Glenn in August last year. It was the first time someone told me that's what it was, dysautonomia. My lying to standing blood pressure difference was huge. My heart rate difference was huge. I would say most of that has gone now. And I think a big part of that is stress management for sure. And whatever the source of stress, right? There's stress in forms of work, there's kids, there's sleep deprivation, there's pollution, there's all of that stuff. So I would say that my dysautonomia is a lot better. Where I'm hesitant is doing, I know that if I did weight training, for example, or if I did, some kind of HIIT workout, or if I went for a run, that inflammation that's triggered as a result of that would cause a dysautonomic like response. My heart rate would stay elevated for longer. I wouldn't recover as well. So it's really being aware of the type of exercise or movement or activity that you can do without triggering it. With the caveat being a small amount of it, of those kinds of exercise might cause adaptation benefit in the future. But again, it's a fine line, and the chronic fatigue world will tell you a lot about that, because there are similarities with long COVID in terms of the mitochondrial dysfunction. So I know that swimming really helps me. I used to swim quite a lot, so I'm not saying you have to be a good swimmer, but I think getting in the water has a very innate calming effect on your nervous system. I know from speaking to Patrick McEwen, the Breath Advantage guy, that the actual swimming and trains breathing patterns as well, which can be really helpful. So I don't become dysautonomic from that. I also do some breath holds during swimming as well, which helps. I tolerate alcohol. Probably wish I didn't sometimes, but so I can drink wine without having a dysautonomic sort of a higher heart rate response than I used to, but still, not back to where I was pre-COVID. So, but I've done a lot, right? Same as you, Jez, right? I don't use the Alpha Stim, although I have some. I just don't have one with me. I do use the Apollo. I do a lot of breath work. I've got an osteopath who's amazing. I've done acupuncture, red light therapy, gong healing, infrared saunaing, everything. Like I've thrown everything at it, and still have some ongoing symptoms, but I'm way better than I was this time last year. Completely.
I think from having spoken to, I'm going to get her name wrong, Svetlana, it's a Russian surname, who I interviewed.
Yes.
Leading expert, Blitshteyn, I think. It sounds like the people who present with dysautonomia outside of long COVID, it's a chronic condition that doesn't really resolve. And I don't know whether, you guys can sort of speak to that as well. What it does seem like to people who suffer with dysautonomia in long COVID, it can and does resolve. The same rules of dysautonomia do not necessarily apply. And there are people making, full recoveries just through doing whatever it is they're doing at this point. And they are still in the minority, unfortunately, but people are recovering, and they were quite dysautonomic before. So this isn't something that we're necessarily going to be stuck with in the way that people who have dysautonomia for other reasons might be potentially.
Exactly. And I think, the whole mast cell aspect of things with the histamine triggering, etc. I think where there is a predisposition there, people are, I've always had predispositions to histamine things. So I was speaking to someone today, and I think, if you've got a history of hypermobility, that's correlated with mast cell MCAS, basically. So you've got to think your presentation of histamine issues is different in different people. For me, it's like swelling, like periorbital edema. It's like, joint aches and IBS. But for other people, it can be other things. So so there is hope out there, but I think you do have to work on it and allocate time for you, and it's quite annoying to see, like, when you do have time, you're on a retreat, for example, and you can see how much your heart rate variability improves, which is a measure of parasympathetic versus sympathetic activity. So it's a difficulty, because if we could all just like sign off our lives for a year, we probably would be in a lot better pace, but that's tricky with life.
I think, Jess, you make a really valid point. So the people that had dysautonomia before long COVID got to consider other conditions like diabetes. Let's not forget that diabetes is a very common cause of autonomic neuropathy. And so it's not necessarily going to get better if they had it before and they've had long COVID and long COVID settles down. That's probably going to be something they're going to be left with. So there's lots of other reasons why people have dysautonomia apart from long COVID. And if those are more chronic in bed conditions, then they're not going to suddenly vanish. I think we've got time for one more question. It's quite an apt one, because it's kind of looking at the prognosis of all this. Do you think the long COVID symptoms will eventually go on their own, or do you think there will need to be some medical intervention to make this happen? And as a side question, what do you think the therapy is most likely to be?
Can I just say something? Because I was thinking about it as we were reading about dysautonomia. Like, you have to think about what dysautonomia is as well. And a lot of people who have a history of post-traumatic stress or have had trauma in their background, that perhaps has not been, processed or talked about or dealt with, that that is still in your nervous system, right? And COVID comes in like a bomb and it triggers off this massive sense of unsafety, which takes a long time to reprogram. So I would really encourage people, and I've done my work in this, Jez has done plenty of work on this, as he would tell you, it's like, how do you, you've got to lose that. You've got to process that at some level, because it will be in your cells, and COVID has just come in and triggered a lot of those feelings. And dysautonomia is the outcome of that. It is dysregulation. So if you can do the breath work, the somatic work, some psychological therapies, all of that really does help. And that has been just my experience as well. So I just needed to add in, and people have asked quickly about neurological vestibular issues, all of that, again, related to brain inflammation, okay? Some of the things that we've talked about an anti-inflammatory approach definitely help neurological and vestibular issues. Antihistamines, H1 and H2, and possibly an additional mast cell stabilizer like ketofen, I can never pronounce that, can help with these neurological and vestibular inflammation, in my experience. We missed that question. I've just seen someone asked.
Oh, sure, yeah. And also, I think for vestibular, ginkgo biloba is very helpful. It's a very good circulatory stimulant. It's very helpful for people with dizziness, vertigo, those kind of things. So that can be quite helpful. It's also, if you've got brain fog, it's also quite a helpful stimulant in a very gentle way. So that can be quite helpful.
I'd like to have a quick stab at that last question, which came in. So I think it's, first of all, it's worth sort of differentiating between post-viral fatigue and long COVID. I've had post-viral fatigue and I now have long COVID. The two with me, and it seems in general, aren't the same. I was not exercise intolerant when I had post-viral fatigue. I couldn't drink, and there's all sorts of other things, but generally speaking, it presented very differently in me. And I recovered spontaneously after about 12 months. If long COVID was simple post-viral fatigue, I think we would by now see most of the first wave as recovered. There are people who have had long COVID / post-viral fatigue, and I'm going to name Paul Garner here, who managed to sort of exercise their way out of it. Now, for some people, that will be possible, but I think that's the minority of cases. I think whether long COVID is going to sort of resolve and whether people are going to get better, we can look at what happened with SARS-1. And there was an article that was just in the press recently about 10 years on from SARS-1, how people were, and the list of symptoms they were describing were identical to long COVID, and this was 10 years later. So I think we have to realistically expect that not everybody will necessarily get better from long COVID completely immediately. For some people, this is going to be a long-term chronic condition. Now, the question is, how many of the people suffering with long COVID are going to be in that long-term chronic sort of space, and what proportion are going to recover? And what are the interventions going to be that help us recover? And until we really understand what the mechanisms of the disease are, it's hard to say. And I think one of the other things that makes it difficult is that I think it's a bit of a smorgasbord, really, when it comes to mechanism. The four sorts of main categories of cause, which have been sort of mooted, are viral persistence, viral debris, autoimmunity, and overactive immune system. And there are subsets of things that might happen underneath all of that, like metabolic dysfunction, dysautonomia, mast cell activation, clotting, all of that sort of stuff. And not everybody has necessarily the same combination of those elements. So when we're talking about who's going to make a recovery and what the interventions are going to be, it's going to depend on which ingredients from that smorgasbord you have as part of your presentation. So some people may respond perfectly to the BC007 drug, for example, that gets in the way of autoantibodies. For other people, that might not be their problem, they may not. So I think this is a very difficult question to answer, and it's ultimately going to come down to, unfortunately, it depends, I think. But that is a consequence of the complexity of the condition and the fact that I think we're going to find that it's not necessarily just one cause, it may be more than one, and that makes it even more difficult.
Brilliant. Thanks for that. That was spot on. Andrew, do you have anything to add there?
Not really. I mean, I agree. I think any condition where it's very, very complex, lots of different symptoms, lots of different mechanisms, is never ever going to be solved by one magic drug. Because drugs at the end of the day work on, a very small minority of receptors. So there's no drug that's going to solve this because it's such a complex illness. It's going to be finding the thing or things which help the person, and that might be a multitude of different things. But just to give people hope, I am seeing people coming out of this. Even people who've had it for 15, 18 months, I am seeing signs of recovery, and they're getting there. So there's hope for everybody. We don't know how long it's going to take. There's no accurate way of giving a prognosis for how long this condition lasts, but there is definitely hope. So you've got to hang in there, guys, and do all these things to try and help yourself, is my kind of take-home message.
Yeah, absolutely. I think someone has asked, and this is quite relevant because I think about this too, about taking fexofenadine, an antihistamine, at a high dose for such a long period of time. And Jez, you're on this as well, at high dose than me. I mean, what do you think that is there an end point, when we can come off these things, or should we be like diabetes, be on a prophylactic drug for life? I don't know. I mean, we just don't know yet.
I tried recently thinking I've been on 2 times 180 a day of fexofenadine. And I thought, which is half the maximum dose, but it's still a pretty hefty dose. And I thought, oh, you know what? I'll just try coming off the Fex and substituting it with a little bit of loratadine or cetrizine or whatever. Within about 3 days, it was just so messy. My skin was blowing up. I was feeling horrible. And I was like, I'm back on the Fex. I took a Fex and I was instantly much better again. So I think we have to sort of perpetually try. And I think we don't want to necessarily be on anything for longer than we need to be. And at the point at which our symptoms get better, then we can start to think, I can start to maybe sort of bring this down a little bit. But we just don't know the answer to that yet.
Mm-hmm. I think with any of these things, don't go cold turkey, right? I think if you've gone from twice a day 180, you'd go to once a day and you taper it off. But I know that's not in your mindset.
Well, no, that's what I did. No, so that is what I did. I thought I was still taking the one in the morning, but then just replacing the afternoon one with something else.
Oh,
but
okay.
Even that I couldn't deal with. Yeah.
Yeah. So I think sometimes an even lower taper might be, but maybe you're just not there yet, right? We're just not there yet. And as long as you're having occasional blood tests that look at your liver enzymes, because all of these pharmacological interventions do have an effect on our liver enzymes sometimes if we're taking, but then again, so does having a load of histamine flooding around your system. So you've got to weigh up the pros and cons of the whole thing, but don't beat yourself up about taking fexofenadine at this point in time. If we're like 3 or 4 years down the line and we're still having to take all these drugs, then you kind of ask yourself what's going on. But I think I see from the trajectory of this illness that, month on month, probably not month on month, but, every 3 months or so you shift, right? There's definitely a shift, unless you get a subsequent, a pneumonia on top, that some people have had a secondary infection, or immunocompromised, which has caused another problem. But I think people are getting better, but it is, you do need to, but this is an investment for the rest of your life, and a lot of people are being forced to kind of look at their stuff, right? Because you suddenly, all your coping mechanisms, like for us, it used to be exercise, or some people have various different coping mechanisms of alcohol or food or whatever, or relationships or whatever. But this is the long COVID is forcing us to face a lot of these things, because we can't rely on them anymore. We have to build back a better body, and to really invest time in our health. But I think it is worth it for sure, from what I see. So yeah, hope that helps. Any other questions? And then I think we have to end because we've gone a bit over time.
I think we covered all the ones that were sent in. I think we've gone through most of the things in the chat box. I think we're pretty much done.
Apart from red light therapy, I mean, red light therapy is helpful for a million things. As one of the reasons you invested in a hugely expensive unit for the clinic in Kensington. We'll send a link to it. I have a red light box at home from Red Light Rising. I used to use it every day religiously. I used to do yoga and stretching in front of it. Improves mood, energy, mitochondrial function, the end product of which is more energy. So big fan of red light.
Yeah, and as I said before, I'm using it very successfully with some long COVID people. I've had a massive improvement in one patient in the last week who's just had 3 treatments, and his energy levels has gone up by about 80%. Now, obviously, that's just one patient, but we're getting at least similar kind of responses from people, that they are getting some noticeable benefit. So it's not a panacea, it's not a magic bullet, but it certainly helps in the armory of this condition. So definitely recommend it.
Great. Well, thanks for all for supporting here today, and really thanks to Jez for your time, Andrew, as ever. And we'll send a follow-up email with some links, and take care. Stay positive.
Thank you. Bye.
Bye. Nice to see you all.